to advocate.
Very good afternoon, everybody. Thank you for this wonderful opportunity, and thank you, sir. For me, I am into full-time simulation, and in a simulation conference, in a national conference, I'm here to speak against simulation-based reinforcement, which means it's like, to a group of children, I'm just going to go and say, okay, see here, toys and chocolate, they're not good for you. So that's the kind of reception that I'm already expecting, which is totally okay, but I still want to go for it. So I'm going to take this as two things. One is the simulation-based reinforced learning, which comes out of deliberate practice that they were all talking about, where because of repetition, there is retention, there is reinforcement. So I'm going to take that one bit. And a little bit about what you said about reinforcement learning or reinforced learning that is just getting introduced. So we are all accepting that simulation causes reinforcement. There is no question about that. And I will have to thank the previous speakers for re-emphasizing the same fact. We are accepting that simulation causes reinforcement. The question here is whether that reinforcement is a boon or a bane. And before coming to whether it is a boon or a bane, I would like to discuss a few challenges in simulation in current scenario in India so that we ourselves will understand what it is. So just to put perspective, from the morning we've been hearing so many things about how medical seats have improved by more than 100% in the last 10 years. Medical colleges have gone from 350 to say 700 plus in the last 10 years. And simulation has been made mandatory by NMC, which essentially means for every medical college, at least there should be 10 simulation instructors so that NMC-based guidelines are being delivered. So we are looking at about 7,000 to 10,000 simulation instructors across the country. Do we have so many instructors? I'm going to ask people who are sitting for, and also to sir, do we have about 10,000 simulation instructors in the country? No. But is simulation made mandatory and is being delivered in the medical colleges? So who delivers that simulation? Simulation causes reinforcement. So if it is delivered by people who do not have credentials to deliver simulation, they will be doing reinforcement of the wrong practices. They will be doing reinforcement of practices that should not be followed. So without having a system where there is a proper credentialing of simulation instructors, we are nowhere close to parting good practices. And sir in the morning was talking about accrediting centers that HSSC is in the plan of doing it. But currently, how many centers in India are empaneled or accredited or have been evaluated by an external agency to say that they are doing good job? So how do we know the value of the courses that are being delivered in those centers? I'm not demeaning any of the centers, but there is no quality check for people who are screaming quality from top of our lungs. We are the ones who are screaming, we want quality, we want patient safety, we want this, we want that. But where is the quality check for any of the work that we are doing? Because credentialing of the centers have not happened, credentialing of the faculty have not happened. The second issue that I feel that Dr. Supe had also shown one amazing repository which is available. How many of you have used that repository? I'm just curious in how many different ways can we teach IV cannulation or intubation or NG tube insertion, and why are we repetitively creating our own modules, creating our own checklists, and who is keeping track of all these checklists and who is validating all of these checklists? I love infection control. In my checklist of IV cannulation, I will give 2 marks out of 10 marks for cleaning the area well before inserting. Whereas a friend of mine would love the procedure and would say, no, this is not required. Let's put 2 marks for identification of the vein, because if the vein is identified well, then there is less problems and there is less complications. So there is no check on what is being taught and what is being evaluated. And despite the fact that there is a central repository, it is not known to everybody and nobody uses it. So that again is a major problem. So same skills are being taught very differently. And then what reinforcement are we talking when everybody is doing different things? The third issue that I have is with assessments. Let's talk about technical skills first. 250 students in a medical college. How many of you, after doing an OSCE, sit with each individual and say where they have gone wrong? Because say, for instance, in an intubation in a score of 10, 1 point is given to visualization of vocal cords before passing the tube. 1 point is given to connect TTCO2 for confirmation. Student doesn't do these 2 things, gets 8 out of 10. They have gotten the passing marks because they have opened the laryngoscope blade, they have introduced it from the right hand side. Of course, process is important, but which of these steps will be really a game changer, and how are we addressing these steps when they miss? So if any OSCE is not associated with a very channelized and a structured feedback, then the learner goes back thinking that I know intubation, I have cleared intubation and I know intubation. So what kind of reinforcement and what kind of skilling are they taking back with them when they are not given a feedback just because of the sheer numbers? So till the time we achieve that, where are we in terms of reinforcement? And coming to non-technical skills, debriefing can change a person for good or for bad. Because if they have done something majorly wrong, which is a patient safety threat, like the most commonest thing that keeps happening day in and day out, how many of you stop the scenario when hand hygiene is not followed in the middle of the scenario? We allow the scenario to run even if they are not following hand hygiene or the gloves are being worn, which means they are in their mind, okay, fine, this is what I have to be doing in my own scenario. So they will be doing those practices. So in technical as well as non-technical skills, and during debrief, if there is a psychologically unsafe environment, then again the kind of learning that they are going to take is going to be very different. So assessment, feedback, and debriefing is also a problem. So I'm not at all coming to the point that reinforced learning is wrong. But unless we address issues of credentialing of individuals as well as organizations, unless we have a common repository of resources and a peer-reviewed, validated checklist, nobody reviews those checklists. Who takes charge and who designs all those things? Unless we have something standard there, and unless we really spend time in helping the learners understand, if they get 8 out of 10 doesn't matter, but where is it that they need to improve, unless we spend that particular time, and unless we are trained to identify what are the major patient safety gaps and stop the scenario even if we are in the middle of a major scenario, I think simulation-induced reinforcement could be a bane. So the whole point is every gift is a curse. A knife could be used wisely, the same knife could be used for killing. But the point is we have a knife. And we are thinking that it is being used very wisely. And I think it's really a responsible thing to start having conversations about things which are not comfortable. Start having conversations against what we believe. Because if we are not aware and if we are not addressing and if we are not mindful, then obviously in few years down the line, simulation-based reinforced learning could easily become a bane and nobody can reverse it because so much reinforcement has already happened. Now coming to the reinforcement or the reinforced learning in terms of gaming, that's very new to medical field itself, and it's just getting introduced into softwares. primarily for pattern recognition. So the best area where pattern recognition and learning quickly happens for software is radiological imaging. And we've still not yet tested it in an area where human brain functioning, human physiology, the environment, we give a cause and then we change the environment. So that is extraordinarily complex. It might take a few years for that to come. So currently, because it is not even developed so well, today it is a bane. Because whatever we have not developed well, we have not understood well, if we start using it, it's obviously not going to work because we will never know the caveats of it. So I rest my case here and I'm going to request my partner to come and continue.
Thank you very much. Thank you, sir, for giving me this opportunity. As we have heard the previous speaker speaking, it is a repeated, deliberate, and intentional thing which should happen. Let us see what is our curriculum in MBBS. When I was a student, we had first year for 1.5 years. Subject also was less, time also was more. But now we are having more amount of subject to understand, to learn, but the time is only 10 months. So with this scenario, with this cluttering of curriculum, where the student has to listen to lectures, has to go to the clinics, has to do his assignments, has to write his exams. Where can we insert simulation in this busy schedule of the student? Even if we are able to insert it, it may be for 1 or 2 classes. There is no repetition at all. So the idea of reinforced learning, where there is a repetition of the work that he is doing, is completely out of question. So what I feel is, in this cluttered curriculum, we should be doing something else. Like I always tell, I think all of you know who is Ashwatthama. Not the Kalki Ashwatthama. The real Ashwatthama had the knowledge about a very, very potent weapon called Brahmastra. But he used it for the wrong things and he caused destruction. What we are talking about simulation today and reinforced learning by simulation is what is very easy for Western countries, where they have 30-40 students per class. But here in our country, the minimum admission is 100 and the maximum admission till now is 250. So with this large number of people, it is very difficult to have fixed hours in their curriculum. Second thing, in the past 10 years, what I have watched, what I have faced regarding simulation is, here we don't have a comprehensive team. Today morning, Dr. Oak was talking about that, where the principal, medical superintendent, the coordinator of the smart lab, the head of the department of the subject, and the medical educational unit sit and determine where we can have this simulation in the curriculum. So what's happening is, once a while someone is coming to the smart lab or skills lab, doing some things, and they are going off. Many colleges, today morning Dr. Supe also was telling that, have locked skills lab. They are open only during inspection. So the students have no knowledge about, though it is included in the NMC curriculum, they don't have any knowledge about the skills. And in colleges where you have a very good skills lab, as madam was telling, they are not skilled. The people who are running the skills lab are not skilled. They think that teaching according to a simulated atmosphere is something like taking a lecture. So they come, give a lecture, and ask the students to do it. Hardly is there anyone to watch what they are doing. Hardly is there anyone to correct them. And if we do according to how a simulation has to be taught, if we want to give the correct feedback to each individual, if you want to correct everything wrong that he is doing, will take a lot of time. And this much time, I don't think the people who are running the skills lab have. Because generally what happens, suppose it's a surgical specialty or a medical specialty or a gynec specialty. They come in their busy schedule or they depute someone in their busy schedule who have no knowledge about how to teach in a simulated environment. So what they are teaching also is maybe wrong. And as Madam was telling, there is no standardization in our country at all. So what we are teaching is what I know. The checklist that I am giving is from somewhere I have downloaded the checklist. There is no lesson plan. The other day, Dr. Oak and Dr. Mahalakshmi had taken a gamification workshop. It was so perfect that there was a lesson plan. The learning objectives were so clear. They went to the minutest detail of how to give some badges to people who won and all that. See, till the last detail, everything was worked out beforehand. So that is simulation. In that way, we all participated. I mean, we were students, interns were there, professors were there, people from other colleges were there. All of us worked as a team. Isn't it, sir? So that is the type of simulation we need, where everything is gone into detail. They think about all the permutations and combinations because they don't know what type of audience they are going to get. And today, many of the students, like today morning, someone was telling that, they are not interested in learning virtually. So they sleep off, which is very common what we faced during the COVID time. So even telesimulation, someone was talking that this could be better if we have someone physically present to see whether they are sleeping or not. Otherwise, what will happen is, no one is interested, they'll be doing whatever they want. So these are some of the defects or limitations. And that is why, as Madam was telling, there is no question of boon or bane, but it is a curse or a bane when such type of things happen. So I would rest my case here and will counter whatever the other speakers would like to tell. Thank you.
Thank you for both the groups for making very passionate statements for their sides of the argument. I would now give about 5 minutes to the proponents to strongly refute what your opponent said, because I think they are coming across too strong. So you better give them a challenge.
Well, that was a very convincing argument, but we have a different take on it, unfortunately. But fortunately for us, we have experts in the room as well, like Adit from MedSim VR, who is developing models that are. I'll reverse a bit and start the course where we were discussing. There is not many trainers in the country to teach simulation, or not enough, credentialing to train simulation. That is true in a manner of speaking, but all these come into play where there is no, where the models used are quite antique, or which require training. But we are in an era where simulation has evolved into objective, using virtual reality, or be it augmented reality, or even the old models where Dr. Annapurna was mentioning, where you can use repetitive practice for suturing. That is long, it's been time tested, and once the methodology is learned, the student can kind of reinforce their learning using those models. But where Adit MedSim VR comes in, he developed a tool where students can, it is quite literally a plug and play model where there is no need for a trainer at all in the room, and you can put on the VR headset and you can train your clinical skills the NMC guided recommended skills, and obviously it is credentialed and tested, and the objective results are laid out. So be it that, when you come to hands-on models like the Symbionics task trainers that are here, those are as well plug and play, where the student just comes in and trains on the models step by step, going from the basic tasks like peg transfer or the hand-eye coordination, be it deconstructs what is seemingly a complex task and deconstructs into a minute a task you can build up onto the final task. And there are objective measures where the student can see how they performed over time, and student can see where they went wrong, and the task doesn't go forward if he doesn't pass through. So I believe there are tools where simulation is reinforced learning is a boon, absolutely, and I am definitely advocating for that.
Yes, I'll give you an example. For example, a laparoscopic suturing. It is a very complex task which is divided into holding the needle, then passing the needle through certain points, then pulling out the thread to a certain length. So it is divided into certain tasks, and only once the student achieves those tasks only, it is said that the student is passed and he can go to the next level. So definitely a level of safety is already there in the system, so that and there is no need for instructor here as well. All my students, they have certain hours, say they have their own IDs, they have to go and log in their IDs and do this task, and once they do this task only, I let them do on the real patient. So there are definitely tools. What you all said are particularly true when we don't have manpower, definitely, but we have ways and means by which we can navigate these difficulties if we are willing to do it. Because definitely without simulation it is way more hazardous. So right structured simulation, and when we think of it, if we want to do it, we can do. Even in my own department, we allocate 2 days for simulation. Be it basic suturing, open suturing, we play standard. I know definitely there is no standardization, but what we think this is a good practice. We show them those videos and we break those videos into key components like needle holding, passing the needle, pulling the thread, different types of knots. So, and they keep on doing. And once we are satisfied the student can do, then we let them do on the patient. And this is what we want to say. Definitely it is better than no training at all.
We also want Adit's comments on this topic.
Yeah, simulation actually is for 3 things. One is the clinical skills, second one is decision making, communication, and patient management. So what madam was talking was about clinical skills, about procedural skills. But when you are doing the procedure, you may become a master of that procedure, but you are not going to do that on a dead patient, you are going to do that on a live patient. So suppose you are applying a needle or something, the reactions, the empathy that you should be having when you are doing that procedure will not be learnt when he is doing it on a task trainer. So the empathy, the soft skills that are necessary when you are doing that is hardly taught. They are taught how to do the suturing, how many centimeters they have to do, all that is taught, okay. But the soft skills part is not taught in our, many of the colleges. Second thing is, when there is a technical malfunction, we sit with the principal, superintendent, everyone sits, charts out a curriculum. We have this many hours for the, so madam was telling 2 hours for the skills lab. And when they come there, suppose there is a technical malfunction. No one knows how to correct it. people in the technical department don't know how to correct it. We have to wait for the people to come from somewhere and do the repairs. So the whole class is lost. In this short time we have to cover the curriculum, whenever such things happen, it is really a discouragement for the faculty, because they have lost one full hour because of the technical malfunctions. So, and all these complex situations, for example, we teach them CPR. They don't do CPR again till the patient comes. They would have forgotten. This is a clearly proved thing, that once you teach CPR during the first year, after 1 year, they have forgotten how to do it. So tomorrow in the house urgency, when they come across a patient with CPR, they have completely forgotten what is the depth of compression, what is the rate of compression, nothing else. So reinforcement, which Dr. Sandeep was talking, is not possible with a large number of people. So though simulation is come to stay, there are a lot of limitations, but with right planning, we can definitely overcome all those limitations, because nothing is impossible, and the way future is by simulation. But what I am trying to say is, simulation as it is being practiced now is not at all correct, is not at all good, and is a real curse to the students. Thank you.
So I'm going to make my stand very clear. Simulation causes reinforced learning. So I'm making that stand very clear. But like Dr. Sandeep and Dr. Anna said, of course, I am a believer of self-learning. For self-learning to happen, like they mentioned, VR is an amazing tool. How many colleges in India have access to VR? Less than 10, more than 10? Less than 10? How many colleges have access to a simulator? Of course, if all of the 700 colleges have simulator, then all of the learning can become self-learning. If all of the 700 colleges have access to VR, learning can become self-learning. I am not against simulation because I am a simulation enthusiast. I propagate simulation. I believe in simulation. I believe in the power of simulation, which is why I know also, after being in simulation full-time for over 3 years, that if it is not done right, if it is not done by the right people, if it is not done in the right environment, and if it is not overseen, and if the quality of the simulation per se is not checked because of all the points mentioned already, very easily it could become a bane and we wouldn't even be aware of it. That's the point. We wouldn't even know. We will be thinking that the class went amazingly well. The students will be thinking that we've never had such an amazing class. But at the end, there will be wrong practices that are carried forward. There will be wrong doings. It will harm patients and it will hamper quality. It will hamper safety. So simulation-based reinforcement learning is there. We just have to be more mindful. We just have to be more aware. And we need to know the challenges so that we'll be able to mitigate them. So there's no point in closing the eye and thinking that the world is dark. It's better to really open see and figure out how we can actually mitigate these challenges. So I am closing saying that simulation causes reinforcement, which could become a problem if it is not mindfully done and if it is not monitored well, not done by the right people. Thank you.
Thank you. So can we have a big hand for both the proponents and the opponents for an excellent debate? I would now throw this open to the floor for discussion. Anybody has any questions, challenges for the people on the stage? Yes, sir. Can we have mic passed to them?
Sir, just few words about it. Ma'am, you are saying regarding the simulation lab, who are the trained people? Who are the ones who are supposed to train them? So it is in the hatching stage nowadays. Who gave the MD person the first degree? Basically, everybody is learning because it's a new one. So obviously, things will develop. Everybody will get their own experience on that, and they can design the actual curriculum which you wanted to say. That is one point I would like to add to it. And one more thing, example is this simulation actually gives margin for error. As I said, a simple funny example is, as a house surgeon, when I was given first chance to suture in the OT theater, I have bent 3 needles. I couldn't close the opening in the surgery. But I didn't have a chance to do this simulation work at that time. But I would have done, definitely my confidence would have been better than what I used to have that time. So definitely the simulation helps. The other things, as you said, it is in the beginning stage. Definitely it will improve, and the number of say qualified teachers for simulation will also definitely develop in this field soon. Thank you.
Thank you. Yeah, Tilaka? I think you're preaching to the choir, but anyway, I'll ask Tilaka to answer.
Yes, sir?
I said he's preaching to the choir. You're already a believer.
No, sir, if I am in your position, if somebody speaks against simulation, I would be like, what are you speaking? I am a believer of simulation. I am a simulation enthusiast. I left my job at AIMS to become a simulation person, and I'm leading a center today at Chennai. And I am not saying simulation, there is no question of no simulation versus simulation. Absolutely not. There is no question of simulation helps. The thing is, if we are not mindful, it might cause trouble. And of course, so in the beginning MD days, there would have been a lot of casualties unknowingly. Now, we are more intelligent to know that the casualties can happen. So we should just try and do stuff to prevent them from happening, which means first we have to know that yes, it can happen. So if we are thinking that it won't happen, then obviously we will allow it to happen and then kind of regret. So we're just trying to prevent that from happening. But point taken, sir.
Thank you. Anybody else has any questions? I would encourage the younger members of the audience. This is your future. Whether you like it or not, you are going to go through simulation. Do you have any doubts, any questions? We have a very experienced panel over here. Any challenges for them? You have had experience which you didn't like or you liked? Anybody? Okay.
So,
yes, ma'am.
So as they said, Srinivas Karu also rightly said, so all are believe in simulation, that's why we have attended this the conference, but it's not against, rightly you have pointed out what are the challenges are there for that. Really we have to overcome that, and simulation nowadays it's giving a very good platform for suturing techniques and all. Previously my father used to say they used to practice on gunny bags. Now we have a very sophisticated, this thing just now I saw, the skin, it's for the individual level also students can use for the suturing techniques. So it's giving a very good platform, and rightly you have pointed out the challenges, and overall in the academic curriculum also there is not equal weightage to all the things. We are all saying that 360 degrees assessment, that is not there. In 3 hours you are deciding everything. The whole 1 year of their the curriculum assessment is only in the university examinations. In 3 hours you are deciding. So that has to be changed, not only for equal weightage for these reinforcement, for these simulation procedures, and equal weightage to all the chapters, all the topics, that should be there. And because it's a national conference, so from this platform we can give that advice. So there should be a specific course for the simulation. So all the medical educators, so they're very well known that how to do the procedure on the living thing or a non-living thing. They can, up to somewhat they can do that. And it's better, you have pointed out, there should be a course so that they are more authenticated to give the training. And this 360 degrees assessment should be there. And they have given this advice regarding establishment of these the simulation labs. At the same time, they have to give the equal weightage for that. So some marks for some amount of the attendance should be there for this simulation lab. Just like our practicals, make it another part. So this lab and the simulation lab, so there should be a separate attendance and separate assessment should be there. So that has to be there. So both of you, you are not against it. So your mind is, rightly you have pointed out the challenges.
Yeah, Dr. Srinivas, go ahead.
Thank you, Madam. Madam has touched upon a very important thing. Mostly in simulation, till now we are having only formative assessment. Summative assessment is not there. When I was talking to Dr. Benberg, in Hawaii they have introduced this as a summative assessment also. As an OSCE station, one will be a simulation. Actually, we can suggest that this can be made compulsory. Like practicals we have for 2 hours, 1 hour of simulation. I am saying, I'll just wait. 1 hour of simulation practice with 5 or 6 questions. Everyone has to pass that. If we make that reality as a summative one, then all the students will really pay interest, because many students don't really pay interest because this doesn't carry marks in the final exam. That is about assessment. Regarding the simulation teaching, actually Dr. NTR Health University Vice Chancellor, we had a talk today morning. They have started it already. 2 simulation courses have been taught to teachers. One was held in Guntur and one was held in Tirupati. So this is going to happen.
Sir, may I remind you, you are speaking against and not for.
Oh, sorry. No, what I wanted to tell is simulation is excellent, but the way it is being practiced now is bad. That's why it has become a curse. Like I told about the Brahmastra. Brahmastra is fantastic, but the way he used it was wrong.
Sir, we are already giving some marks for OSCE, madam. In 200 marks of practical exam, we are giving 60 marks for OSCE. But it is not standardized. That is the problem. So it is up to the department what you put under OSCE. Are you giving a MCQ? So right now in our department, we are putting practical OSCE questions only. So it is up to the departments now. Soon it will be up to the university. Soon it will be up to the NMC. So hope is there and it's starting, and all my students are doing OSCE, 60 marks out of 200 marks.
So, excuse me, myself,
Sir, let us just finish on this point and then I'll come back to you.
No. So the whole point is, if every simulation instructors are like you, there will not, this debate won't happen. That's the question. that is the aim. So till the time everybody is like them, we have to be mindful. That's all.
Okay, sir.
Myself, a professor of surgery from Hyderabad. So simulation is a better thing, a new type of things, just like a rehearsal to put some drama or acting drama like that, I feel. Suppose I am a general surgeon telling that suturing is a technique. We used to have only in the house surgeons, have the opportunity to suture. But nowadays, the curriculum is there from 3rd year on after passing anatomy physiology. And the NMC itself introducing that a student of MBBS should feel that he is a doctor. And like that, they have been given some village adoption to know their problems and everything. So it is there in a final examination also. There is commission skills and how to examine. There are OSCE's 5 stations are there. The different models. So if it is done in a better way, it definitely improves their skill. So if it is not done in a proper way, the results will be less. I can't say that the bone definitely skill course. But we need more teachers, and over the teachers they are teaching in the medical college, they are doing all these things, but they have to spare time. We need adequate teachers to teach them in a proper way. Thank you.
Thank you. Anybody else? Yes.
So, given this opportunity, I'm very thankful. But I'd like to add my personal experience. When we were teaching students or when the simulation was not there, I have personally seen students with shaking hands and shivering hands with a lot of sweat to perform a small simple task like catheterization. But once we started to simulate this catheterization, I could see the drastic change in the approach of the students towards the procedure. They were very lot more confident performing the procedure, but at the same time I agree with Srinivas sir saying that there was lack of empathy. Empathy has to be also be trained so that the skill, a goal of teaching the skill is perfect. We want to teach both the skill and also empathy part, but we are presently teaching only skill part. We are not really concentrating on the empathy part. If we can do that one, we are 100% successful in the process of simulation of the skill. Thank you.
Okay, I think it's time to wind up this very, very interesting, interactive debate. I think both the parties have made their points very, very well. And I was a little worried. I thought there will be a physical fight breaking out on the stage, but luckily it didn't come to that. So I'll just sum up what has gone on so far. So coming from the opponents, I will start with the opponents. Both of them are agreed that simulation is the way forward, and that this is definitely a process that encourages and promotes reinforced learning. However, the objection they were raising was that there are practical difficulties in implementing this in the present context. So the answer to that obviously will be, it is up to us who are all sitting in the hall, who are attending out of interest, to find out the ways out of these practical difficulties. And we do know that now the trend is going towards simulation. I have been involved in this for the last 20 years or more in this country, and I've seen the growth of simulation from what it was earlier to what it is today. You would never get an audience like this, maybe even 5 years back, for a simulation conference. So that speaks to the fact how quickly it is growing. And coming to Tilaka's point that reinforced machine learning and all is a new technology and we should wait. My question is, why can't we be in the forefront and start using these technologies, research this technology? After all, if 1960s, if GABA could say, I'll develop an anesthesia simulator and do something with it, when there was absolutely no evidence to say that it works, and you see where we are today. So I think we should be at the forefront of the technologies for that. One of the points made, of course, was the lack of empathy or the affective domain when we are teaching simulation, but now there is enough evidence of ways to overcome that even when we are teaching people tasks and skills, and it is up to us as simulation educators to use those techniques to make sure that the students get a complete picture rather than just isolated skills training. Coming now to the proponents, I would say that we are not out of the woods. There are a lot of ethical issues related to using reinforced learning for simulation. I think Tilaka had pointed out that a reinforcement can be a negative reinforcement if you are not careful. Clinical cases are very, very complex, and it may not be easy for us to have a reinforced learning system which will encompass all the complexities of an actual clinical patient, and that is something that we have to be aware of. All these toys look nice and new and shiny and very attractive, but do they actually provide us the learning outcome? We need to have evidence for that. So these are some of the things that we need to think about. So with that, I think we will end the debate over here. Thank you for both parties for such an excellent debate, and thank you for the audience for a very interactive discussion. Thank you.
Sir, I request Dinkar Pai sir to felicitate our speaker, sir.
I request Dinkar Pai sir to felicitate Dr. Tilaka Muttaya. Dr. Sandeep Ganni. Dr. Annapurna. Dr. Srinivas Rao.
Thank you, speakers. Thank you, Dinkar sir. Immersive simulation is an emerging technology where the clinicians can create real-life case scenarios, act and treat accordingly. We have a short video on how we can treat a trauma scenario with multidisciplinary team. Let's have a look onto it.
అరే యాక్సిడెంట్ అయ్యింది, కాల్ చేద్దాం అంబులెన్స్కి.
హలో
హలో 108 అండి?
చెప్పండి.
రాజానగరం హైవే దగ్గర ఇక్కడ ఒక యాక్సిడెంట్ అయ్యింది, లారీ బైక్ గుద్దుకున్నాయి.
ఎక్కడండి సెంటర్?
కనకరాజు కోవా సెంటర్ దగ్గర.
ఎంతమంది ఉంటారండి?
ఒక్కళ్ళకి అయ్యింది.
సరే అండి, వస్తున్నా.
ఓకే, పక్క నుంచి వెళ్ళండి, కొంచెం పక్క నుంచి వెళ్ళండి.
కొంచెం ట్రాఫిక్ కంట్రోల్ చేయరా బాబు? కళ్ళు తెరవండి, ఒకసారి నా వైపు చూడండి. హీఈస్ రెస్పాండింగ్. పల్స్ ఫీబుల్గా ఉంది. ఫస్ట్ ఎయిడ్ బాక్స్, స్ప్లింట్, సీ కాలర్ తీసుకురారా?
ఎస్ మ్యామ్.
ఇంకోటి తీసుకురారా? చాలా మంది 1 2 3. గా సెక్యూర్ చేసి ఐవి ఫ్లూయిడ్ బాలస్ ఇవ్వ.
ఓకే మ్యామ్. మ్యామ్ 18 గేజ్ క్యాన్లా?
ఓకే, సెక్యూర్ చేసి ఫ్లూయిడ్ బాలస్ స్టార్ట్ చేయి.
బాలస్ స్టార్ట్.
ట్రెనెక్స్ 1 గ్రామ్ ఐవి స్టార్ట్ ఇవ్వ.
ఎస్ మ్యామ్. మ్యామ్ ట్రెనాక్స్ 1 గ్రామ్.
ఇంజరీ అలాగే లెగ్ ఇంజరీ కూడా ఉంది. ఒక 5 మినిట్స్లో మేము మీ హాస్పిటల్కి వస్తాం, మీరు మొత్తం సెట్ చేసుకుని ఉంచండి. సరే అండి.
క్రాష్ కార్డ్ రెడీ చేసుకోండి.
సరే మ్యామ్.
సిస్టర్ మానిటర్ కనెక్ట్ చేయండి. విష్ణు ఎయిర్వే చూసుకో.
ఓకే మ్యామ్.
హిస్టరీ తీసుకో ఒకసారి.
Excuse me. Excuse me. మ్యామ్ పేషెంట్ కాన్షియస్ ఉన్నాడు, ఎయిర్వే పేటెంట్ ఉంది.
మేడం బయట హార్ట్ రేట్ 60 మ్యామ్, బీపీ 50/60 మ్యామ్, SpO2 68 మ్యామ్, GRBS 34 మ్యామ్.
పల్స్ స్టేబుల్గా ఉంది. అను ఇంకొక ఫ్లూయిడ్ మార్చు. ఢిల్లీ పోలింగ్ క్యాథెటరైజ్ చేయి. హారిక శాంపిల్స్ పంపించండి ల్యాబ్కి.
మేడం రైట్ సైడ్ బ్రీత్ చెస్ట్ రైస్ లేదు, అండ్ ఆస్కల్టేషన్లో కూడా బ్రెత్ సౌండ్స్ వినిపించట్లేదు.
సిస్టర్ అల్ట్రాసౌండ్. ఓకే
మ్యామ్ 2 లీటర్స్ ఫ్లూయిడ్ ఇచ్చాము, బీపీ 60/40.
సిస్టర్ ఒకసారి బ్లడ్ బ్యాంక్కి కూడా బ్లడ్ నీడ్ ఉండొచ్చు అని యాక్టివేట్ చేయండి. ఢిల్లీ బ్లీడింగ్ ఎక్కువ అవుతుంది, ఒక ప్యాడ్ ఇవ్వు.
ఇవి అండ్ 0.5 cc టెటనస్ టాక్సైడ్ ఇచ్చేసి అయ్యాం.
Sir, PCM given.
ICD సెక్యూర్ మ్యామ్. లాగ్ రోల్ టెక్నిక్ యూజ్ చేసి బ్యాక్ ఇంజరీస్ చెక్ చేద్దాం. ఓకే
1 2 3 షిఫ్ట్.
లుక్స్ లైక్ దేర్ ఆర్ నో ఇంజరీస్ ఆన్ ది బ్యాక్. న్యూట్రల్ పొజిషన్. లెవిట్రాస్టమ్ 1 గ్రామ్, మిథైల్ప్రెడ్నిసోన్ 2 గ్రామ్ స్టార్ట్ ఇవ్వు. అను యాంటీబయాటిక్ 1, మానిటల్ స్టార్ట్ చేయి. ఓకే
Levetiracetam given, ma'am.
మేడం పేషెంట్ జీసీఎస్ డ్రాప్ అవుతుంది మ్యామ్.
పేషెంట్ వైటల్స్ కూడా డ్రాప్ అవుతున్నాయి.
నేను ఎయిర్వే సెక్యూర్ చేస్తాను మ్యామ్.
హారిక అసిస్ట్ విత్ ఎయిర్వే. మ్యామ్ పేషెంట్ బ్లడ్ గ్రూప్ ఓ పాజిటివ్.
అది వచ్చేసి ఒకసారి
సిస్టర్ ట్రాన్స్ఫ్యూజన్ కి బ్లడ్ బ్యాంక్ ని ఇవ్వమని చెప్పండి. దీక్షిగా అడ్రోబిక్.
ఓకే తీసేద్దామా? కార్డ్స్ విజిబుల్ ట్యూబ్. Tube in place. Airway secured, ma'am.
Bilateral equal identity tube is in place. మ్యామ్ బ్లడ్ వచ్చింది. ట్రాన్స్ఫ్యూజన్ స్టార్ట్ చేయండి. సరే ట్రాన్స్ఫ్యూజన్ స్టార్ట్ అయ్యింది. హారిక. ఎస్ మ్యామ్. హోల్ బాడీ సిటీ ఆర్డర్ చేయండి. ఓకే మ్యామ్. అలాగే ఓఆర్కి ఇన్ఫార్మ్ చేయండి. ఓకే మ్యామ్.
I hope you got a brief idea on immersive simulation through this video. The most interesting part of the day is here. We are heading into the quiz on simulation by Dr. V.N. Mahalakshmi ma'am and Dr. Frank Omnath sir. Dr. V.N. Mahalakshmi ma'am is the Dean of Health Profession Education and Professor of Pediatric Surgery at AVMC Puducherry. And Dr. Frank Omnath sir is Associate Professor, Department of Physiology, AVMC Puducherry. Please welcome them on the stage. We have exciting prizes coming up for the winners, so I request everybody's active participation for this.
request the audience to connect to the Wi-Fi. In case of internet glitches, you can just connect to the Wi-Fi.
Leave it, man, leave it.
Slide changer we can't use. We are using Mentimeter.
Okay.
He will stand here.
Fine.
Mic.
No, I think we can use this.
Can you give me the mic?
Good afternoon. Good afternoon. Okay, are you ready to play? Okay, we are going to do a quiz, but it would not be like a quiz normally you see. You call some teams and they will only be answering. Whoever is in this hall can take part in this quiz. Everybody, it is open. How many of you are willing to play? How many of you are willing to play? Hey, only 6 hands are going up. Can we cancel the quiz, Shevanti? Can we try once more? It's a multiple choice question quiz, so it isn't very difficult. You don't have to give the answers. And
probably the cash prices, if you announce that the cash prices or the prices
Shevanti, please announce what are the exciting prices you have in
store. So the first winner will be getting stethoscope. So second winner will be getting the planner, and third winner will be getting the pen stand. So they are not just simple ones. So we made it in a way that you would like. So please have your active participation.
Okay, where is our friend Shravan? Shravan is also ready with chocolates. So we have 8 rounds. At the end of each round, whoever is leading, Shravan is going to give chocolates. Are you? Yeah, chocolates ready. So now let's again ask, how many of you want to take part in the quiz? No, I want the hands to go all the way up. Now what about this bunch? What about that bunch? What about that bunch? Yellow color salwar kameez.
Don't worry guys, it's not about your academic subject, so you can peacefully play it.
See, it's only a question. There is no negative marking. It's only questions about simulation, and you can always click any of the answers. There is a 1 in 4 chance that you would be right anyway, right? So before we move, I want you to connect to this Wi-Fi. All of you have connected? Okay, we will be using a platform called as Mentimeter, and Frank here is the quiz master. I am the one who will announce the questions. So we are going to use a platform called as Mentimeter. I want you to open the browser. There is no need to download any app and all. Open your browser and type menti.com and put the code. Join quiz and put the code. Or you can scan the QR code. Either way you can join.
If you are lazy, scan the code.
Monica, you can also join. Okay, Monica, Avinash are there in. All done? All done?
No ma'am, we have to give few more seconds. Are you done guys? Guys at the back, are we done? Can you put a thumbs up if you are done? Yes? Okay, still scanning, the last row still scanning.
Anyone still scanning? Go in fast. Yeah, I need to come, don't worry. Okay, to familiarize you to this Menti platform, okay, when we say that the question is coming, you need to look at your phone. Please don't look at the screen, look at your phone. you would find the questions and the options. It's an individual game. Can you please keep quiet? Thank you. So it's an individual game. You will have to click any of the 4 options, and for each question we have also given some clues in the form of pictures. Okay? And also, what area of simulation? Is it about simulation terminology? Is it about learning?
With nicknames.
Bahubali and Captain America and all. Okay, please join with your own names. Right? Are we ready to play? In case of any discrepancy, quiz master's decision is final. Okay, are we ready? Thank you. You have presented, huh?
No, I didn't. Still there.
Already some people have answered.
Percent is still there.
Why it is not coming? Why it is not coming?
Display.
Why he is connected? I think some problem. My laptop is not connecting. This one has to be connected.
Yes.
What happened?
I think laptop went to extended mode now. I think it is.
No.
Just give it to me. Where is it?
I want to open this.
One second.
Meanwhile, it's getting settled, right? And it is one of the interesting platform. The thing is, you being a faculty or you being a student, this is the first time you'll ask all your students to look into the phone when a class is going on, not at the screen. Okay, so we are hoping that you would only enter on. Questions will be displayed. Look into your phone, right? It will take some time for the options to come, right? Each right answers will have some set of marks. The person who clicks fast, who answers fast, has an added advantage mark.
I'll do it.
You got it? Yes? The person who is giving the right answer will get a mark, but the person who is giving the right answer the quickest will get more marks. So it's like a friendly competition, right? So the fast you click, the more the marks you get. Yeah? It's enjoyable. Yes, we'll see that.
What do you want?
Settings.
Morning it connected.
Yeah.
Okay. We see only few people, 12 people have answered. Okay, now 14. How are you today? That's the first question, just to get you into the mentee mode. What I see here is the number of people who have answered. Okay. We'll move on to the actual quiz. This is the first question coming up. So be ready to play. We have issues connecting to the quiz.
I think internet connected.
1 second. No, why? Sorry. is not connected to the internet. Yeah. But I don't know the Menti password. Somehow people have answered. You have to say.
That's the first question.
What does the term fidelity mean? Look into your phones and answer. Sound.
Look at the time is running.
You can't increase this. 49, 50 people have answered. Okay, out of 89, 83. Okay.
Okay, out of that, 32 people have answered correctly.
So fidelity refers to the degree of realism you bring into simulation. Okay? It's not assessment criteria, it's not reliability, it's not accuracy. Got it? We'll move on to the next question. Look into your phones. One mic, we'll put it here, Frank. What is the primary goal of debriefing? You see the number of coming there? That's the number of people who are answering. Above that is the timer.
Time up. Okay, 45 people have answered correctly.
So the purpose of debriefing is to facilitate reflective learning and critical thinking. You learn what you did right in the simulation and what not. Okay? Ready for the next? Okay, I see 78 players ready. Look into your phones. Question number 3.
Last 2 seconds.
Okay.
Only 13 people have got it correctly.
So when we are talking about simulation, right? Hey, no, don't go to the previous question. Go back. When we talk about events of instruction, simulation actually involves eliciting performance. Okay? So let's see the next question. The last question in round 1. The most famous pyramid in all medical education. What does simulation assess? You have only 20 seconds for this question.
You have only 20 seconds for this question. Last 5 seconds.
Fantastic. Miller's pyramid assesses show how level. It's not knowledge, it is demonstration of what you have learned, right? So that finishes round 1. Let's see the leaderboard, Frank. Sound.
Okay, as we said, the fastest and the right person is Dragon Knight. Can you please put up your hand or please get up? Who's Dragon Knight? Yes, please get up. Wonderful. What's your name? Okay, I'm not able to hear his name, but Dragon Knight gets the first prize. Second prize, Saint Elmo. So that's why you should put your name, right? Third is Parashuramalu. Okay. Fourth is love side. Okay, wonderful. See guys, you can catch up in the second round. Right? Be sportive, answer quick.
Okay, we are moving on to the round 2. Round 2 is about teaching learning activities. Answer fast to get more points. Look at your phone. What is the role of standardized questions in simulation-based education? Why do we use SPs?
Only 15 seconds more. Last 10 seconds.
Fantastic. So SPs provide consistent clinical scenarios. So if you want to simulate a patient with Parkinsonism, if you have an SP, whether one student asks that patient or 25 students ask the patient is SP is going to act out in the same way. That's the purpose of SPs. So that was question number 5. We'll move on to the next one. 36 of you got it right. Look at your phone.
Thirty seconds. Last 5 seconds.
Fantastic. In simulation scenarios, the complexity increases as the learner learns more. For example, for a first year student, we will be teaching only BLS. But when they go to third year, we will be teaching them how to do in a cardiac arrest situation. When they become interns, they run the code blue, right? Complexity increases. And what is the principle behind this? The principle is what is called as learner scaffolding. You support the learner till he is able to stand on his own. So, introducing to clinical complexities in simple ways. Make him climb one step at a time rather than making him jump from there to here. That is what is called as learner scaffolding. We had only 6 people who got it right, but it's okay, you can catch up. Frank, are we ready for the next question?
Yes, ma'am. They are all ready.
Are you all ready? Let's see. Okay, so many.
30 seconds, come on.
Fantastic, 34 of you got it right. So, I am working in a group. My friend is little better than me in this. I know little less than him. I learn from my friend. So, that is the gap which is between the learner and the next possible person, which we can bridge by peer assisted learning. So, all of us need not be at the same level in a simulation, team training, we can learn from each other. That's what it means, right? 34 of you got it right. Okay, that's the last question of the next round coming up, the second round.
Come on guys, be ready.
81, 82 are there ready. Good. Look into your device. What is distributed practice? How can you distribute practice? Oh, this question has only 20 seconds.
Last 3 seconds.
All 84 answered. Fantastic. When you actually distribute this learning over a period of time, If I learn catheterization, it's not that I'm going to spend 3 days continuously in skill lab doing only catheterization. I'll spend 1 month, one session in a month, then 2 months later I'll come and practice. Another 3 months later I will practice again. That's what it means. So 42 of you got it right. That finishes round 2. Let's see the leaderboard.
So,
Shravan, are you ready?
End of round 2. The leaderboards are here. Dragon Knight. We missed the Dragon Knight here now. Rishik. Oh, you changed your name. Very good, Ben. Okay. Rishik leading again with 6,050 points. Give him a big round of applause.
Hey. Rishi, are you a diabetic? Can you eat 2 chocolates? We'll share, okay?
Okay, next is Saint Elmo. Who's Saint Elmo? Sir, come on. We can't let the kids beat us. Come on, sir. Yes. Next is Sampath.
Who's Sampath?
Sampath, come on, man. Very good. Give him a big round of applause. Swapnili. Swapnili. Okay, very good, man. And okay, all the guys, girls, what happened?
Nirupama.
The fifth, we are not giving it.
Nirupama.
Okay, Nirupama. Ma'am, you're there. The organizing committee, we are always with the support. Okay. Are we ready for the third round?
Okay. Right. Are we ready? We'll go on to the first question in third round. What is the purpose of using mannequins or task trainers? Lateral team, I want you to win this round.
Last 15 seconds. 1-5.
It's only 20 seconds for this question.
Last 5 seconds.
Fantastic. Wonderful. Right? You use them to simulate real life procedures and scenarios so that you can save trouble to the patients. So that is what is the purpose of using mannequins. So most of you got it right. Good. Let's move on to the next question. Look into your device.
The most effective feedback during simulation-based training is 20 seconds more. Sambat sir, come on.
No, this round Nirupama is going to win. Shravanti, are you in the game?
Last 5 seconds.
Yeah, I see 89, 91 people. We have more participation now as we go along.
That's wonderful.
See? Go back, please. So the answer is, it's a specific feedback provided during or immediately after simulation is what works. Not 1 month after, not 1 year after, right? Not during the session. Fantastic. Most of you got it right. Let's go on to question number 11. You like this music?
In simulation-based education, the role of pre-briefing is 2. 20 seconds. Ten seconds. 5 seconds. Okay.
Hey. So setting expectations for the simulation and providing what are the clear learning goals is what is the purpose of pre-briefing. Frank, you're a fantastic DJ, Frank.
Thank you, ma'am. I think we are moving to the 12th question. That means end of?
Round 3.
Round 3. Come on, guys. That's the last question. Rishik, ready? Sambat sir, ready? Come on, guys. In simulation-based education, in situ simulation is conducted. 20 seconds. Ten seconds. 5 seconds.
Fantastic. Okay. When you do the simulation in an actual clinical environment, When you do the OT simulation in the OT or emergency room in the emergency room, it's called as in situ simulation. Not what is happening in the skill lab, but happening in the actual workplace. Okay, that's question number 12 for you. At the end of question number 12, let's look at the leaderboard.
Are you ready for the leaderboard? I'm excited. Rishi, come on man. He's still maintaining with 8,755 points.
No, but for this round, let's give Saint Elmo the chocolate. Do you agree, Rishi?
Why? Because look at the leaderboard. He has given the most fastest answers this time. So we are giving the chocolate to Saint Elmo.
Who is Saint Elmo? Okay, sir.
That's a Sambat sir. Not Sambat sir, sorry.
Mohan.
From Mohan sir.
That's one physiology faculty from another.
That's why I'm encouraging him very much, you know.
Hey, Santoshi, who is that? Intern.
Ma'am, Santoshi, we know Santoshi. Right?
Okay, she is there now. See number 3.
Yes.
Okay.
Welcome back, Santoshi. Okay, are we ready for the next round?
Okay, this is round 4.
In simulation scenario requires a team to manage a patient with sepsis. The primary purpose of debriefing after the simulation is to.
Why do you
20 seconds.
debrief? Team trainings. Look into your phone and answer. Done?
10 seconds. 5, 4, 3, 2, 1.
Oh, 91 people answered and 34 people got it right. Actually, I
Wonderful.
gave a clue. You are reinforcing teamwork concepts and communication skills in the debriefing. So that's what you do in team training exercises. Fantastic. We'll go on to the next question. Question number 14.
When designing a simulation scenario for trauma management, which component is crucial to enhance the fidelity of the simulation?
Remember what I told you about fidelity? Bringing in realism.
Ma'am, you are giving clues.
Pona podu friend.
Last 15 seconds. Last 5 seconds. 93 have answered, ma'am.
Fantastic. And most of them got it right. So when you create a mollage, like there is a wound, there is a bleeding, there is a fracture, it increases the realism in trauma scenarios. 58 of you got it right. Fantastic. Good going. Let's move on to the next question, Frank.
Question number 15. Which aspect of a simulation scenario best supports the development of critical thinking skills? 20 seconds only. Last 5 seconds. Only 84 have answered this time, ma'am.
Oh, fantastic. But we got about 1/3 of them getting it right. If you make the scenario as realistic as possible, like what they showed, no? When the accident occurring anywhere, instead of that, if you say the accident occurred in Rajahmundry highway, and then you actually simulate an emergency room, actually simulate an accident, ambulance environment, it increases the realism behind the scenarios. 38 of you got it right. Let's move on to the next question.
15 is over, so next is going to be the question number 16. I think that would be the end of round 4. Guys, be ready. Last question for round 4. When planning a simulation for interprofessional education, the primary goal is to 25 seconds. Last 10 seconds. 75 answer, keep going. 5 seconds. Wonderful.
Fantastic. Most of you got it right, more than half. So if you're having an interprofessional team in a simulation scenario, it is basically to enhance the collaboration and teamwork between different professions. So when you treat a real patient, you have a doctor, you have nurse, you have the other healthcare workers, you have the emergency tech, everybody. So it's not to teach procedures at that time, it is to teach how to work in a team. That is what is the most important aspect. Most of you, 55 of you got it right. So let's see the leaderboard, Frank.
Guys, are you excited?
I am only excited, they are very quiet.
We are excited, ma'am. Yes. Rishi, again, congrats, man. Rishi is again leading with 10,531 points. Give him a big round of applause. Next, our Mohan sir, 9,814. Santoshi, come on, catch up. Okay, 9,262 points. Sarvan, come on, man, 8,767 points. We have a new upcoming in the leaderboard, that is G. Rajiv Kumar. Welcome.
Okay.
I'm chocolate to whom?
Chocolate. Who is the first person? Santoshi this time. Because she has come up. Who is Santoshi? Yeah, there she is.
Santoshi is
our intern who helped us in the workshop. Are you the same? Okay.
Can we give a round of applause? We are halfway through the quiz. How is the platform? Is it fun using the platform?
Is Mentimeter fun? Right. So we are halfway through. Let's move on to round 5. The first question in round 5.
What is the most effective way to evaluate the impact of simulation-based education on clinical practice? 15 seconds more. Last 5 seconds. We have 70 people climbing up.
Done. Okay. See, the most effective way in which you can analyze whether your simulation is effective or not is how they work in the clinical environment. There's no point in looking at the pre and post test scores. There's no point in looking at the ASCII. They are only formative. But actual benefit comes when they work in the clinical setting. So the answer was only clinical setting. How many of them got it right?
16.
Only 16. Okay, that's a tough question. Maybe it is a little difficult. Let's see the other questions in this round. But remember, you need to actually translate simulation outcomes into clinical outcomes.
Look at your device. 30 seconds. Fifteen seconds. Last 5 seconds. 81 people in climbing. Come on, guys. Time up.
Very nice. So when I run a scenario on pediatric asthma, the outcome I want from my students is, it's not how to recognize asthma, but whether they are able to recognize and initiate the treatment plan for asthma. So that's the clinical practice outcome we want for a scenario which involves management of asthma, right? Okay, next question.
What is the most appropriate tool to assess communication skills during a simulation?
This everybody should get it.
Last 5 seconds. 4, 3, 2, 1.
Okay. In ASCII, you use a checklist. If you want to assess communication skills, you use an ASCII station and you use a checklist to assess that. 1/3 of you got it right. 90 of them did, 30 got it right. So the last question of this round coming up.
End of round 5, the last question. Be ready, guys.
Please look into your device.
The feature of high fidelity simulation most beneficial for training in rare emergency conditions or scenarios in. Last 10 seconds. Time up.
So we use high fidelity simulators compared to other low fidelity simulators or standardized patients because we can simulate a wide variety of physiological responses, right? All other things are not the correct answer. We had only 11 people answering. That was a differentiator question. Let's see who is winning in this round.
For every question, we get a lot of ooh and ah from that side. So I hope somebody is winning there.
Okay, let's see the leaderboard, Frank. Ooh ah is making a difference.
Yes, ma'am. Again, it's Rishik leading with 12,331 points. Congrats, Santoshi climbing to the second place with 11,117 points, and Mohan sir with 10,989 points. And we have a new entry, few new entries to the leaderboard. Barefoot Contessa.
Who is this man? Barefoot Contessa?
Welcome, sir.
Okay. Yeah.
We have Rahul.
Who is Rahul?
Hi, Rahul. Okay. We have Harsha.
Oh, new person. Good.
Okay. Harsha is the fastest among in this round.
Who is Agent 19 man? Nice man. Who is this man? Who is Agent 19? Who is the James Bond here? You don't know which name you joined? Who is Agent 19? If you get the prize, then you won't get it. Frank, whom do you want to give the prize to?
I think we'll give to Barefoot Contessa.
Ah, we'll give the chocolates to Barefoot Contessa. Sir, please receive your chocolates from Shravan's assistant because Shravan is a big boy. He doesn't want to do all those things.
Are we ready for the next round?
Okay, this is round 6. We have only few more questions to go. 10 more. Let's see what is the question.
When conducting a simulation for team-based resuscitation, the most effective way to improve team dynamic is?
Fantastic. The best way to ensure that the team works properly is to assign roles and clarify their roles. Half of you got it right.
The next question is, what is the primary benefit of using simulation to train teams for mass casualty incidents? 25 seconds. Last 5 seconds. Timer.
Yeah, 1/4 of them got it right. When you want to actually run a disaster drill or training for mass casualty incidents, you want to check whether your systems are in place, your protocols are there, and everybody is aware of it. So that was the right answer. Next one, question number 23, I'm sorry.
Question number 23. What is the most important factor in ensuring the psychological safety of participants during a simulation? 25 seconds. Anybody can join if they have just arrived. You can go to menti.com, you can use the code, you can just join the quiz. Last 5 seconds.
Fantastic. So, the most important element in learning and ensuring psychological safety of participants is to have a non-judgmental environment. Safe learning environment is essential for psychological safety during simulations. So that's the correct answer. 34 of them got it right.
So the last question for round 6. Be guys ready? Question number 24. What is the most effective way to ensure that simulation scenarios are aligned with the learning objectives? Last 10 seconds.
Everyone has voted. Big round of applause for everyone, please. Okay. So the most effective way you will ensure that the scenarios are aligned with learning objectives is to use feedback. Once you run the scenario, take feedback from participants, check if they really felt that that was the learning objective which was covered in the scenario, and update the scenario based on their feedback. Okay, 20 of them got it right. Okay.
So end of round 6.
Leaderboard.
And congrats, Rishik is leading with 14,186 points, and Santoshi with 13,335 points, with Barefoot Contessa of 12,933 points. And we have a new entry, Swapnil. May I know who's Swapnil? Yes, congrats. We have 12,424 points.
Okay, chocolate goes to Swapnil. Hey, can we clap at least, man? We can't be so wimpy kids.
We have just 2 more rounds. That means we have only 6 more questions.
Yes.
Okay, guys ready? We have round 7.
You need to answer fast.
Question number 25. When using simulation for procedural training, what practice is essential for skill retention? 30 seconds. We have last 10 seconds.
Fantastic. You want a skill to be retained. It's not enough if you spend lot of time on that skill at one go, but you need to have periodic refresher sessions. I think we covered that in a previous question also. So, but that's the correct answer. 27 of you got it right. Okay, next question. Question 26. Only 4 more to go.
What is a significant advantage of using mannequin-based simulation over simulated patient scenarios? 20 seconds. Last 5 seconds.
Fantastic. 35 of you got it right. You use mannequins because you have great control over physiology. You want to keep the heart rate 60, you want to keep the heart rate 120, you can do. But in a simulated patient, you can't keep, right? So that's the difference in between using a mannequin-based simulation and a SP-based simulation, right? 35 of you got it right. Okay, next question.
Question number 27. What is an important consideration when selecting a location for an in situ simulation? 25 seconds. Seconds. 5, 4, 3, 2, 1. Come on. Time up.
fantastic, the relevance of the location. You want to run a OT scenario, you have to run it in the OT. You can't run it in the casualty ward or in the labor room. So that is the most correct answer. Okay, next question.
I think the last question of round 7.
We see some interesting avatars.
Question number 28. What is the major advantage of hybrid simulations? We have 30 seconds. Last 10 seconds. We have 79 and climbing.
Yeah, 51 of you got it right. So in a hybrid simulation, you have an SP, a simulated patient, and a mannequin. The main advantage is that you can simulate the communication skills in the SP and the physiological responses in the mannequin and procedural skills in the mannequin. That's the advantage of hybrid simulation, where you can use best of both worlds, right? It's like hybrid car. It can run on electricity or it can run on petrol. Okay.
Okay, end
Shall
of
we
round
see?
7. Are we ready for the leaderboard?
Yeah.
Congrats, Rishik, again maintaining with 17,707 points, and Barefoot Contessa with 15,538 points. And welcome back, Mohan sir, with 15,445 points. Rahul, again with 15,073 points. And we have Santoshi, catch up Swapnil. And we have new one on the leaderboard, Millie.
Who's Millie?
Oh, sir.
Okay. So the Rahul, did you get a chocolate? Okay, Rahul gets the chocolate this round.
Applause,
Can we
man.
clap, man? Last 2 questions.
Okay, last round. Just 2 more questions. Yes. Keep your fingers ready on your smartphones. Okay, ready? Last 2 questions. Question number 29. What ethical consideration must be addressed when using simulated patients? 25 seconds. Last 10 seconds. I think maximum will give right answer for this. Last 5 seconds.
Fantastic. We have only 18 people answering for this. It's not that we have to ensure that the SP is trained well. Then only the scenario can run. But the question was, what is the ethical principle in using SPs? Whether it is the participant or the SP, we have to ensure their psychological safety. If SP says that I have already lost a child and you ask her to play the mother of some very sick child or grief counseling when child has died, then it is not a safe environment for SP. So you need to ensure psychological safety of your participants as well as your standardized patients. Okay?
Last question of today's quiz program. Guys, ready? Rishik, ready? Mohan sir, ready? I think hope Santoshi ready, Rahul ready.
Santoshi, win man, please.
Okay.
No sound from that side.
The last question. Question number 30. What is a key ethical consideration when using video recordings of simulation sessions for educational purposes? 25 seconds. Time up.
Fantastic. Informed consent from the participants. Whenever you're recording something and putting it or using it, you need to take consent. 37 of you got it right. So that finishes this quiz. Big round of applause for Frank.
And for ma'am.
Thank you.
I
Let's
hope you
see the
enjoyed this
leaderboard.
platform. Are we ready for the leaderboard? Rishi, excited? Yes?
Going. Gone. Okay.
Yes,
Rishik
the
is
winner
first.
is Rishi with 19,496 points.
Can you put some music? Okay, who's the next?
The second prize is to Barefoot Contessa, I think, sir. I don't know.
Who is Barefoot Contessa? Sir, can we know your name, sir? Dr. Rajesh.
Okay, we welcome Dr. Rajesh, who won
Sir,
the
up,
second
up,
prize.
up.
And third prize is Saint Elmo. I think I welcome Dr. Mohan.
Okay. Can we have the organizing team to present the prizes to them, please? This is also from Physiology
Oh
Department.
my goodness, I think it's an excitement day for me. There are a lot of physiologists here around.
Frank, can you present the third prize? Third prize. Sir, come on. Hey, guys, big round of applause. Sir, can you come over and present the second prize? Second prize. Okay. Mohanty sir, can you come and present the first prize, please? Sir, be there, sir, 1 minute.
Can we have another big round of applause for Rishik, please?
Rishik, what are you?
Ma'am, I'm a first year MBBS student.
Oh, that's wonderful. Straight off foundation course, I think it's paid enough.
How did you get all the answers right? Okay. Sir would present the prize to first year student, man. Nice. Rishik, I think you should smile. Okay. One special prize to our helper, but who has always been seated, no? Shravan, please come, bring the chocolates also. Shravan volunteered to help us for this round. Frank? Thank you. Hey, wait, we'll take one photo. Okay. Okay. Would anybody like to give a feedback about this? Rishik, give us feedback about this quiz.
This was a fun activity, and I would like to thank everyone.
Thank you. Any other person wants to give feedback? Shravanti.
That was really very fun, ma'am. So even as a part of Smart Lab faculty, even we tried to participate, but we couldn't make it. We were in top 30, but never in top 10. So we are very happy that our first year MBBS student made it to the first position. And also congratulations to second and third positions, sir. So hope you enjoyed the activity, and we are very happy that we had the active participation. And moreover, this is one way which we can integrate to teach them when we teach them actually in the skill setup. So that's really a good idea. And also we learned many questions, ma'am, answers for many questions on the other hand. So thanks a lot, ma'am, for it.
Thank you. Any other feedback from the audience? Shravan, would you like to give some feedback?
Ma'am, it's a very interactive session, and it's very enthusiastic, and we are waiting very much for the next question to answer, so that we may get one step ahead, so that but it also shows us knowledge never lies in the eldest or in the lowest. It may reside anywhere, so we can see that the first year MBA student has got it. Yeah.
Right. What did you enjoy most about the quiz?
Chocolates.
Oh, he had the chocolates, so he enjoyed maximum. I would like to thank Frank, who has been helping me with this quiz. Thank you, Frank.
Thank you, ma'am.
Thank you very much for your active participation. It was nice having you all here. Over to you.
Thank you, ma'am. Thank you, sir. Congratulations to the winners once again.
As we draw day 1 of Simulcon 2024 to a close, I want to take a moment.
Hey, we have one paper.
Sorry everyone, I would like to welcome Dr. Tejasvi, first year postgraduate general surgery, GSL Medical College, for her paper presentation.
A very good evening to everyone. I am Dr. Tejasvi Rentachintala, surgical resident from GSL General Hospital, and my guide is Dr. Samiranjan Nayak, HOD and Professor of Department of General Surgery, GSL General Hospital. Today I am going to be presenting my paper, which says Perceptions of Simulation Training, a survey of surgical residents, attitudes and learning preferences. Coming to the introduction, simulation training enhances surgical skills effectively. Faculty shortage hinders regular simulation sessions. Standardization needed across simulation training programs. High fidelity stimulators provide realistic learning experience. Structured feedback improves resident skill development. Integrating simulation into curriculum is essential in the training of surgical residency. And coming to the overview of the paper, this paper is a survey on simulation training effectiveness. And the inputs were analyzed, which were the perceptions of surgical residents. And the responses were 100, the participants in the survey were 100. And it also concentrates on focused on realism and modality usage in simulation training. And key insights drawn from surgical residents' responses. It also highlights the potential areas for improvement. My aim and objectives through this paper is to assess the effectiveness of simulation training, to evaluate realism of training scenarios which are being used, identify preferred training modalities of various surgical residents, and also to determine the optimal time for simulation sessions. And it also aims to gather suggestions for improvements and feedback, and also enhance overall training quality. And coming to my materials and methods, this paper is a survey design which was structured where we distributed a structured questionnaire using Google Forms, which included multiple choice questions, Likert scale, and open-ended questions. The participants were surgical residents from various training levels, and responses were collected anonymously to ensure unbiased feedback. And as I already told, the data collection, the surveys were distributed electronically via residency group chats, and the analysis tool that I used was Microsoft Excel for descriptive data. And coming to the statistical analysis, among 100 surgical residents who participated in the survey, among them, all the surgical residents, it was unanimous that every surgical resident feel that simulation training is effective, and only 60% feel that it is realistic, and among them 80% feel that it should be mandatory. And also the preferred time for surgical residents, most of them voted for 1 to 2 hours per day in the simulation training. And the preferred simulation modalities was VR training and task trainers hit the list, and the next two comes high fidelity mannequins, as we already discussed in the previous talks, and computer based simulation. And in the survey, in the open-ended questions, the major feedback that we got is the challenges. So the main challenge in simulation training is lack of faculty. There is very insufficient number and heavy clinical workload limits involvement. Since surgical residents should be trained by a surgeon, and unavailability of surgeons who are trained in training simulation are very rare, and also resource limitation, as we already discussed, and lack of standardized protocols across residency programs, need for a structured curriculum to enhance comprehensive exposure. And also, because of the residents' busy schedule, difficulty in incorporation regular sessions without disrupting clinical duties was a major challenge. And coming to the feedback and assessment the lack of structured feedback after simulation exercise, need for constant evaluation metrics to track progress is a major deficit. And these were the verbatims that I've received. A PG told that simulation training is significantly boosts my confidence before performing surgeries, which shows its effectiveness. And the scenarios are realistic but still could be improved with better it can mimic better of the complex clinical conditions. This was a verbatim from a senior training level resident. And a resident quoted that more frequent simulation sessions would help me to feel prepared for real life procedures. And it would be great if we had better guides to trainers despite of the infrastructure we have in our training center. And the shortage of faculty, as it has already been grasped from the survey, the shortage of faculty for simulation training sessions limits our availability to practice and frequently and receive adequate feedback. And coming to the conclusion, there is a strong support for simulation training in the entire survey, and also the participants value effective and realistic experience, as we see. And implementation of simulation training needs increased faculty involvement, standardized protocols, resource allocation, and integration into the residency curriculum. And there was an overall positive impact on surgical education which was observed. And the major lag that we found is the implementation, which needs a major improvement. These were my references. Thank you.
Thank you, Tejasvi ma'am. As we draw day 1 of the Simulcon 2024,
We have one more paper presentation by Dr. Frank Omnath, sir.
Good evening all. I am Dr. Frank Omanath, Associate Professor Physiology from Arupati Vida Medical College. I'm here for the oral paper presentation, but more than a paper presentation, we would like to continue the story of what ma'am said in the morning, how she set up the skill lab and accomplished it. And this is a part of that journey of first responder program. Here we are empowering communities in emergency preparedness, outcomes of a large scale first responder training program in Puducherry. So, introduction into the sudden cardiac arrest. You know, when there is a sudden cardiac arrest, we know there is a golden hour. Golden hour is somewhere around 3 to 10 minutes. What happens when there is a sudden cardiac arrest? The time frame is very less. If somebody helps us, say in that golden hour, we won't be able to reach the hospital within that stipulated time. So somebody who has to help us, who is going to help us is the bystander. If the bystander is not going to help us within that stipulated time of 3 to 10 minutes, it will result in mortality. Right? The mortality in our country for cardiac arrest, there are almost 10 crore people dying, 1 crore people dying in a country where the mortality of sudden cardiac arrest is of 1 million per year. See the number, it is huge. Okay, how to prevent it, right? How to prevent it? The number of person, I told you the bystanders, who can help us when there is a sudden cardiac arrest is very less. It's a mere of 0.1%, right? If this bystanders, we can increase the number of the people who have the ability or who has the skill to use a basic life support to revive a patient, can decrease the mortality of the country. So in 2024, the government of India has demanded for mandatory BLS training in all the higher education institute to reduce sudden cardiac arrest death rate. So there is only, as I told you, there is only a mere of 0.1% of Indian population are aware of the BLS techniques, and there is lack of community awareness. So this leads to a community awareness, right? So the government has mandated all the higher education, even non-medical higher education institutes to implement the BLS so that the rate of cardiac arrest comes down. We at Vision Center of AVMC, we regularly conduct our BLS, ACLS and Jeeva Raksha Emergency Core Life Support, and as a part of that, a community outreach activity. So one such community activity is our Beach Road activity for World Trauma Day and Cardiac Days, where we had an overwhelming response from the public, and they were demanding us actually to conduct a large scale so that a lot of publics are being trained in the BLS activity. So this led to our initiation of our first responder program. Our first responder program started, our plan to start this first responder program is we had a primary aim to train the members of the police, other first responders and the members of the public like auto drivers, taxi drivers. These are the people who come in contact with the first point when there is a sudden cardiac arrest. And we wanted them to train not just in cardiopulmonary resuscitation, that is CPR. We also wanted them to train in basic first aid and emergency responses and to trauma techniques, especially how not to move a cervical spine, how to provide a stability to the C-spine. Our objectives were to promote emergency preparedness and community safety and empowering individuals with skills to respond effectively in critical situations. Okay. Our primary goals and objectives were, our methodology started with our primary goals and objectives being basic first aid, CPR, and emergency response to trauma techniques. And our target audience were police personnel, NCC people, NSS people, and non-medical higher educational institute candidates. So we started the program. The most important thing is finance and budgeting. So we had a very good partner for the finance from the Rotary of Chennai, and we started our publicity and outreach via radio partners, Hello FM, media partners, newspaper ads, and other social media, other various social medias. So for this, we need all our training resources, for especially our mannequins, which are provided by the AHA and the National of Life Savings and from Lateral. The main instructors was from our institute and also from the Emergency Medical Society, and we have a huge number of volunteers to help us for this training program. And most importantly, we had external instructors and internal instructors. So we had to standardize the instructors so of what needs to be taught to all. So we had a proper instructor training program in our lab, and then we had an instructor manual, we had a validated checklist, and we have the outcomes measured. So this was how our program started. This was our methodology, right? You can see this picture, like how we arranged the mannequins. These were all low-cost, low-fidelity mannequins provided by the AHA and the national NLS team, right? And we had all the police personnel started training. We see, as ma'am said in the morning, it was a large group, but the large group was condensed into a small group discussions, and we had a small group teaching of the skills. And we had the Honorable Lieutenant Governor of Puducherry inaugurating the program, and we had a number of people from NCC, NSS, and other various institutes. So how many people were participated? Total of 3,310 people participated, and the training event was structured into 6 sessions which spread over 3 days. The total number of instructors were 30 to 35 per session, and 30 instructors were internal, that is from our Institute of AVMC, and we had 25 external instructors from JIPMA and various other institutes like Indira Gandhi Medical College, Manakula Vinayagar, and etc. There are a total number of volunteers that we had almost around 50 volunteers from Rotract of AVMC students, and the total number of institutes which we train like NSS, NCC were around 8. We analyzed the results in Kirkpatrick's module of reaction, learning, behavior, and results. The reaction being the feedback, and there were overwhelming feedbacks from the public. These are few of the pictures where the public were giving the feedback. So the feedback, so we asked them, as usual we do, we asked them what went well. What went well was effective instructional methods. The feedback said that they really enjoyed the interactive sessions. It was much better than listening to lectures. And instructor competency, they all praised the instructor. They said that I feel very comfortable asking questions, and the instructors were very knowledgeable. In a term, they said the instructors were non-threatening, and then they were very approachable. Engagement and interaction. The group activities helped me from my peers, to learn from my peers and stay engaged. So the engagement and interaction, we were not like a class. We never said that, you don't talk to others. So when one of the participants is not able to help, the other participants pitched in themselves to help them out. So that was the peer learning came from. The practical skills development. The hands-on practice was excellent. it really helped me to understand what to do. So they praised the practical skills, and they said they were confident enough to take the skills and to propagate it further. Logistics and organization. The training flowed well with breaks, sessions at the right times. So they also appreciated our exact intervals, how our the lunch was provided, how the snacks was provided. So everything was well appreciated. And these were the feedbacks of what went well. And there was also feedback of what could be better. So though we had a lot of instructors and stuff, so there's room for improvement. 3,000 people, so we are very short on time. So we have to certify them. But still people want to practice on more. So we were lacking that particular time. So they were telling it would be helpful to have additional practice scenarios to reinforce what they learn. And enhanced equipment availability. See, because we were dividing a group of 8 people, 20 people for one group which had 4 mannequins. So they were like, we had a very short of time. If there was more mannequin, it would be helpful for us. Spacing and session timing. Some sessions felt a bit rushed, and it was hard to keep up with everything being covered because use of use of medical terms, so they felt like we were rushing it a bit. More realistic scenarios, and some of the feedback, see, we gave them a realistic scenarios, but being on the spot, on the road, they are saying like we want more interesting and realistic scenarios where we could really help them. And clear instruction and guidelines. At times the instructions were confusing and it was hard to know what was expected. Few felt because there was a language barrier within some instructors, so that could have been avoided, and we are looking forward to improve it. So that was the takeaway. The takeaway is from the feedback that they learned the skill, right? They wanted more equipments and they wanted more hands-on. So that's what we are taking it away from the feedback. And some of the newspaper articles, these are the media highlights which showed about our first responder program, including the English and the Tamil paper. The results being the mean average scores of pre and post tests. So the pre-test shows somewhere around 27.5% of the total score of 50, and post-test it was somewhere around 42.9. So you can see a huge value, and it was statistically significant. So it really shows that the people who came there learned something about the skill. But though there were 3,310 people, the number of people certified were only 2,330. For the rest of the people, we did have a remedial class kind of thing. We provided them again a chance to repeat it. We gave them special one-on-one interaction with an instructor and a participant, where almost 80 people were again recertified, but others we were not able to recertify them. So we told them, if you want to be certified, please come back to our skill lab. We are always there to help you. So again, in the Kirkpatrick model, so what we saw is in the learning, knowledge and the skill. Next we'll go to the behavioral pattern. The behavioral change. See, there are changes from the participants. See, this is a person, he is from a non-medical institute. This guy came as a first responder participant, and he is working as a social worker in a nearby school. So he went to that school, he trained those students. So that was a wonderful, behavioral change from the participant, like what's happening. So these are all motivational things. So definitely then we should be, we being the host, then we should also have some behavioral changes. So we continue to do our community outreach program, right? So we started to continue our community outreach programs. See, you can see even it was drizzling, it started to rain, but the public never moved. They wanted to continue the CPR. It was raining, but still you can see the raindrops, but they were, they were very adamant that they wanted to continue, and they said that, so if it's raining, I wouldn't live a life alone. So that sort of enthusiasm was wonderful from the public. And the last with the model is the results. What's the impact is? The impact of this program, first responder program, led to this. This is one of a first responder trained person who tried to revive a school student on the way on the road when she saw someone suddenly collapsed, right? And then she did revive him. And that was a wonderful thing. And that's the impact of our first responder program. We would like to continue such programs in the future on demand for the public. So the conclusion of this paper is the first responder training program marked a significant step in enhancing emergency readiness in the city of Puducherry, achieving its objectives of training community members in saving life skills. The large-scale program has laid the groundwork for continued community engagement and resilience building initiatives. So the takeaway from this programs were community-centered training can significantly increase local emergency response capabilities. See, that's the impact. Our impact showed, the behavioral changes of them showed that they are ready to propagate it. They are ready to take away the steps in helping people. Hands-on skill-based training enhances participants' confidence and readiness of real-life emergencies. The simulation which we did there with them, it really helped them to help people. And then strong partnership with health organizations amplify outreach and resources for such initiative. Though we have a good impact, though we have a wonderful behavioral change, but without such resources, we won't be able to continue it on a large scale. So the resources and the partners are very important. We are thankful for them. And this is our wonderful team. I think ma'am also showed it in the morning. That's our group of instructors and that's our group of volunteers. I thank them all. I thank the partners, Rotary of Chennai. I thank AHA, National Lives Saving and Emergency Medical Society. And foremost and most importantly, I thank Dr. V.N. Mahalakshmi, the Dean of Interdisciplinary Studies and Health Profession Education of my institute and my guru and mentor. Thank you, ma'am. Thank you all. So if anyone wants to have any question, it's okay. Yes, ma'am, of course.
See, I know not many people are listening, but at least for the people who are listening, what we want to tell from this particular presentation is we need to actually think little big when we want to actually achieve certain things. And we need to, most of the times we are very hesitant to approach people. But when we open up and ask people, they are more than willing to help. For example, the whole thing was conducted inside Jipmer Auditorium, which was given to us free of cost. So like that, we had multiple people coming and helping us in this particular endeavor. And I really thank my team. They were fantastic. Like, you just can't believe the energy levels we had during this continuous 3 days of program. It makes sometimes things worthwhile. That's the thing. Thank you, Frank.
Thank you, ma'am. Thank you all.
Ma'am, I request you to come onto the stage for conducting such an exciting quiz. We have a prize for you. Yes. I call Dr. Sunita ma'am, HOD Gynecology, to give the prize.
Hello.
As we draw day 1 of the Simulcon 2024 to a close, I want to take a moment to reflect on wealth of knowledge and inspiration we have shared today. It has been an incredible journey through the latest trends, challenges, and breakthrough in simulation. I would also like to acknowledge impressive contribution from all our speakers. Your insights and expertise have sparked the new ideas and inspired all of us to think about the possibilities ahead.
We have another day full ahead of us with even more exciting discussions and opportunities to learn from each other. So have a great evening and come back tomorrow. Thank you.